Hi, this is Brian Kim. I want to share with you this very interesting case. I thought this was going to be a routine cataract surgery, and it ended up being quite challenging. I did this patient's first eye. This patient has some zonulopathy, small eye, but weak zonules. And I put in a capsular retention ring and a single piece of acrylic lens in that eye, and everything went fine. For the second eye, I tried to do things a little bit differently, and you're going to see how things go really sideways. And I almost had a serious problem with this case. So this patient has extreme zonulopathy, and you'll see what I mean when I say the capsular bag gets not just incarcerated within the incision, but also incarcerated with the IOL injector. And then you're also going to see how I place a capsular retention ring with my minimal zonular stress technique. So this is the eye. You can see the cataract. It's not really that obvious, but this patient also has a shallow chamber. Again, this is a small eye. This is a high power lens. It can be like 29 diopter lens, shorter axial length. This is a corneal marker, which will help me to center and size the rhexis. And this is a paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. As I said, this patient has somewhat of a shallow chamber, and the lens tends to bulge anteriorly. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then using the cannula to control the eye, and when I'm ready, I enter. And I use that same cannula to control the eye for the rhexis. These are the sharp tip micro-rhexis forceps by Moria. I puncture the center and I pull down towards me. You can see the tear doesn't go the way I want to. Part of this, I believe, is due to the zonulopathy. You can see there's some zonulopathy. And you see these fibers on the anterior lens capsule as well. I'm going around circumferentially, trying to stay within the corneal mark that I made so I can achieve a well-centered and sized rhexis. I try to grab every 2 to 3 clock hours or so. As you can see, very little OVD egress with these nice micro-rhexis forceps. Burp some viscoelastic out, coating the cornea with the viscoelastic. This helps minimize the requirement of my assistant to keep the eye wet. It'll just stay wet for me. This is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, start to get a nice wave. Once I get the wave, I lift the lens up, and then I decompress the bag, pushing the lens away from me, and it causes that wave to propagate from the contralateral side to the proximal side. And then once it's nice and separated, I'm able to spin the lens without difficulty. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. You can see because of the high-powered lens, this is a purple sleeve, and I used the 3mm blade for this case. Remove the surface epinuclear material, place the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, fracture the lens in half, that's double chop, placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and crushing the lens in half, and that is a cross chop. Using some vacuum to grab that first quadrant up, cut it in half with mechanical forces, and then emulsifying it. Lifting that second quadrant up out of the bag with the chopper very easily, grabbing it with some vacuum, and then emulsifying it. Turning the second heminucleus in front of me with the chopper, hooking the peripheral lens with the chopper, pulling it centrally toward the phaco tip, which is positioned deep in the bag, and that is another cross chop maneuver, fracturing that second heminucleus in half. Placing the chopper under the third quadrant, hooking the peripheral lens, and it pops right up, and then emulsifying it. Doing the same thing with the fourth quadrant, lifting it up, but then performing another cross chop maneuver, grabbing that piece with some vacuum, emulsifying it, and then grabbing the last fragment, which is attached to the epinucleus, and emulsifying it. Turning the chopper sideways, trying to get underneath the epinuclear material, and then using some vacuum to remove the rest of the epinuclear material. So far, very straightforward, very safe systematic lens disassembly using double chop, cross chop, and mechanical fracturing forces. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the I&E handpiece, lift the iris to reduce any reverse pupillary block that was there, grabbing the cortex from anterior to posterior, starting subincisionally, peeling from anterior to posterior, going around circumferentially. I knew this patient had weak zonules and needed a CTR in the first eye, so of course I'm very mindful of that for the second eye. I'm trying to grab very carefully, trying to avoid aggressive vacuum near the bag, but you see right here, I grabbed the bag here. You can see there's quite a bit of traction. I'm being very careful, trying to grab some of that lens material without grabbing the bag. But again, this just kind of confirms, just like with the first eye, that there's quite a bit of zonular laxity. Trying to very carefully grab some of those lens remnants without pulling on the zonules. Switching to polish mode, polishing under the rhexis edge. This lower flow setting is a bit more gentle on the zonules in the bag. Pulsing the BSS into the subincisional capsule fornix, making sure the bag is nice and clean. You can see as I pulse, there's quite a bit of stria in the posterior capsule. Again, another indication of some zonulopathy. Switching to the cohesive viscoelastic, turning off irrigation first, and then pushing the cohesive viscoelastic. You can see all the stria in the posterior capsule as I inflate the bag. So at this point, I'm thinking I'm going to put a 3-piece lens into the bag. I have my larger incision. I have my purple sleeve. I thought, okay, let's just put in a 3-piece lens and everything will be fine. So I placed the cohesive viscoelastic cannula through the side port. And then as I push, I find that there's quite a bit of resistance. So as I push, look what happens. I'm pushing and pushing, and it's causing the chamber to collapse because of the pressure gradient from inside the eye to outside the eye. And as that pressure gradient is occurring because I'm gaping the incision and I'm pushing so much, that pushing is also causing the chamber to collapse. And look, the capsular bag is going into the wound. And so like, oh my goodness. So then I try to take the lens out. And as I take the lens out of the incision, look at the bag. It's almost coming off. And so I'm really surprised by this. I've never seen this before. And what I've concluded was the bag is incarcerated not just within the incision, it's actually incarcerated within the injector. That's why when I pulled the injector out, it actually caused the bag to come off more. So obviously I've stripped a lot of zonules, and what's my next step? You know, do I have to do a Yamane technique? Do I have to eat the bag? Do I have to do a vitrectomy? All of these thoughts are going in my head. But the first thing I need to do is, again, one, get this bag disengaged from whatever's keeping it incarcerated. Is it just within the wound? I don't think so. I think it's caught within the IOL injector. And so my next step is I'm not going to yank out the IOL injector. If I do, the entire bag is going to come out. And then I'm really hosed. And then I really have to then do a scleral-fixated lens or something like that. So instead, I start to deliver the lens even though it's outside the eye. And as I deliver the lens, it pushes the lens out, it pushes the OVD out that was within the chamber of the injector, and it released the bag. So thank you, God. The bag is released. Now what do? I have this bag that's, again, very loose. You can see the zonules are just very tenuous nasally, and part of the bag is still incarcerated within the wound. So what am I going to do? Am I going to sweep the incision like you would if you had like vitreous or something? Again, not something that I would recommend sweeping vitreous anyways, but would you sweep and try to get the bag in? Well, my thinking is if I do that, I might rip the bag. I might actually traumatize the bag if I tried to do a sweeping motion. So I didn't think that made any sense. Again, the reason why this bag went in, number one, was it was pressure differential, high pressure inside the eye because of the OVD. And then when I open up the incision to put the lens in, it caused a pressure gradient, and all that OVD started coming out. And with it, the bag started coming out. Once the bag contacted the wound, it also contacted the lens injector, and then it got trapped in it. And so my solution was to burp the viscoelastic out and praying to God that the bag is not going to be torn as I'm burping the wound. So I burp, burp, burp. I'm burping as much as I can, and I'm trying to make sure I equilibrate the pressure inside and out first. And once I'm confident of that, then I push cohesive viscoelastic to push the bag back into the eye. So at this point, I'm like, okay, I have no idea what's going to happen here, but it looks pretty good now. The bag is back into position. I don't see the bag flopping around. It's intact. And theoretically, I'd say, 2 to 3 clock hours of significant zonular loss in that nasal quadrant. And maybe I'll be able to place a CTR in. And so this is a CTR, and I always do that minimal torsional stress technique, and you'll see again how I do that, and I do this every time with all my cases. I place the injector hook within that first eyelet, and it turns right in, and I always like to have it go in counterclockwise, and it's going to come out clockwise. And I have a Lester hook. I'm going to open up the incision with the Lester, slide the CTR injector into the eye. Here I have some bubbles. Don't want bubbles to get in the way when I'm dealing with a difficult situation here. So go ahead and try to evacuate the bubbles here. And also you can see that the bag is starting to collapse a little bit more. You can see some wrinkles in the bag. So I'm not going to put the CTR in when there are wrinkles in the bag. Never put a CTR in when there's wrinkles in the bag. If there's wrinkles in the bag, then the CTR will get caught in the wrinkles and rip the bag. You need to have the bag fully inflated when you're going to put the CTR in. And then you can do this technique where I'm going to put the Lester through that leading eyelet. And as I deliver it, it's going to wind the CTR in tightly. And as it's wound tightly, it's going to minimize any stress and torsional stress on the capsular bag and the zonules. And then it just pops right in. So I have, again, minimal rotational stress technique by hooking the leading eyelet with the Lester. Now the CTR is in the bag. I'm going to forego the 3-piece lens and go with the single-piece lens. You can see the lens went in very nicely. The injector went into the wound very nicely without any stress. Again, I think that was the main problem, that the wound was a little tight. And as I pushed with the injector, all that OVD came out. In this case, the injector was nice and small enough, and the wound was big enough that it didn't cause any stress on the wound, and therefore I didn't have any OVD egress. The single piece acrylic lens went into the bag very nicely, and then I used the viscoelastic cannula to reposit the haptics in the bag. So remember, just use whatever you have. You don't have to switch instruments, especially when the lens is opening up. Just use what you have. Use that viscoelastic cannula that was already in your hand. So I get underneath the lens, removing all the viscoelastic from within the bag, switching to polish mode, and then visco mode, removing all the viscoelastic from the anterior chamber. And lo and behold, I have a perfectly centered lens within the capsular bag. The bag is intact. I don't see the bag falling. It's not dislocating. And so I am very, very fortunate, even though I had about 2 to 3 clock hours of zonular stress. Obviously, it's not completely disinserted because the bag is still round. Or in addition to that, the CTR is providing that equatorial support. And because I have 270 degrees of zonular support, even though I have 90 degrees of lacking support, the CTR is able to provide that equatorial plane of support with that ring. And at the end of the case, I hydrate my incision. So what's the learning point here? Number one, and when you have zonulopathy, don't try to burp the wound. If you have high pressure in the eye, try not to have high pressure in the eye, because as you decompress the incision to put the lens in, the bag can come out. I mean, that's an extreme case. I've never seen that happen before. Clearly, this is severe and extreme zonulopathy. If you have extreme zonulopathy, that means that bag can just come right out of the wound, which it did here. Not only was it trapped within the wound, but it got actually tethered to my IOL injector. And so when I started pulling the IOL injector out, it caused the bag to start ripping. And so obviously I noticed that and I stopped, and then I tried to very carefully disengage it by pushing the IOL forward, and that caused the viscoelastic and the lens to come out. And by doing that, it untethered the IOL injector from the incarcerated bag. And then I burped the incision to equilibrate the inside and outside of the eye. And then once I did that, I was able to push the bag back. And so again, Crazy case. I've never seen extreme zonulopathy where the bag actually got incarcerated in the wound like this. But I hope this is helpful to you, and I hope that this teaches you that when you have severe zonulopathy, never take it for granted. Always respect the weak zonules. Try not to create high pressure differentials, which can cause the bag to come out like it did in this case. Fortunately, this patient did very well, and post-op day one, the patient has some visual disabilities for other reasons, retinal issues and so forth, but uncorrected vision post-op day one was 20/40, and she was very happy. So I hope this was helpful to you, and I thank you for your attention.